Good morning, everybody, and dear Mr. Chairman and dear colleagues, especially for the Vasila, I want to thank for the invitation. Now I want to talk about the endovascular treatment options in pelvic venous disorders. Just to make a quick, sorry, just to make a quick start, I want to give a brief description what we are talking about. The pelvic venous disorders, as we know that it has four clinical presentations, which is the chronic pelvic pain, pelvic varices, renal symptoms, and leg symptoms. So it can be in combination of all of these, let's say, clinical presentation. And when we look at the underlying pathology, we have two underlying pathologies. One of them is the reflux, and the other one is the obstruction. Especially when we talk about in mainly the pelvic congestion syndrome, many times we talk only about the reflux part, and we sometimes underestimate the part of obstruction. But all these pathologies should be our own mind to decide any type of therapies. And when we look at the female pelvic circulation, we know that there is a four interconnected system, and we should think about all of them to decide what to do. Which starts from the left renal vein and goes to the lower extremity veins via escape points. And there are two important reservoirs in the abdomen and pelvis, which is the pelvic and the renal hilar plexus. These are really important. And we have two patterns of disease, which is described as compensated or uncompensated. And who decides this? The most important is the existence of collateral flow. If there is the collateral flow, it's compensated, and if there is not, it is accepted as uncompensated. And at the UIP 2019, Dr. McMeister offered a new classification system, I think, which we will gonna use in the next years, which has SVP classification, S for symptoms, V for variceal reservoirs, and P for the pathology. And as we see, we have four variceal reservoir parts, starting from the renal hilar varices going to the lower extremities. And when we look at the guidelines as a method of therapy, it is suggested for the pelvic congestion syndrome and pelvic varices with coil embolization, plugs, or transcatheter sclerotherapy, either used or combination. So let's go to what's offered. We have the embolization coils, so it is accepted as a standard therapy in combination or not with foam sclerotherapy. And we know that there are a lot of different type of fibers. These procedures can be done either transjugularly or transfemorally, but mainly I prefer to do the transjugular approach because, especially for the right-sided ovaric vein, it's much more easy to go from the jugular. It can be done under local anesthesia, and either you can make it a daily practice, or you can just send the patients afterwards. And here is one of my patients. Is a lady of 45 years old, mother of 3 kids. She came with a severe pelvic pain, and for this lady, she has a bilateral ovaric vein insufficiency. I never do both ways at the same time in my practice, because I always try to treat the most, let's say, symptomatic side, and then according to the patient's let's say symptoms relief, I go to the other side. I just leave it like this. For this patient, I treat with coils and the foam sclerotherapy. And 3 months later, the patient came still that I have the symptoms, so I make the right-sided coil embolization with polydacanol. Excuse me. But I just wanted to show you, if you look at the screen, it is different from what I showed you on the first image. These pushable coils are, either they are not migrated from the ovaric vein, but their places are changed. So, especially then I changed my practice to the other type of coils. So you have to anchor these coils in order to, let's say, prevent from coil migration. And this is another patient with internal iliac vein insufficiency. So you should always keep also in mind that not only the ovaric veins, but also the internal iliac veins is a source of, let's say, reflux. You should look for it. And we have another option. It's ethylene vinyl alcohol polymer. So it is also can be used. to treat pelvic congestion syndrome. And in this patients, I combine the coils with this onyx, so it's also a good option. So, but you have to make it in a very slow way, otherwise it can also migrate. So, in order to prevent any migration, you have to be very, let's say, patient, and you should inject it very slowly. But the results is okay, and mainly when I use this onyx therapy, I always do it as a sandwich technique, which I combine with coil every time. And of course, no therapy is safe. We have also some advancement which can be as a vein perforation, transient pain or fever, some thrombophlebitis at the access points. Coil migration is also is an important issue. That's why you should select right sizes of coils. And we have the embolization plaques. Due to the highly possible collateral network, it is important to use or combine it with other therapies, and also you should select the right sizes. Percutaneous sclerotherapy can be used, and also it can be combined with surgical therapy, and also direct puncture of the, let's say, veins with foam sclerotherapy is an option. And for the compression syndrome, we should use stenting therapies. And when we look at the literature, and there are good results, especially from the Dr. Whiteley's clinic, as you see at the 2 years period, many of the patients are free from reflux. And when we look at the long terms, and as you see in the slide, there are a lot of sources of insufficiencies, so that's why I put this. Any combination can happen, but when you look at the 6 years data and 8 years data, many of patients are benefiting from this. And Onyx has also good results. As a conclusion, PCS is a complex and underdiagnosed cause of pelvic pain, and we should need both dynamic and static testings, and we should always keep in mind the compression syndromes, and that's why we should think globally. And when we look at the results with coil and foam, it's promising. Thanks for listening. So we invite you also the next year UIP meeting in Istanbul.
But I think it's time for questions now. We have 3 minutes. Please, quick question, quick answer. I don't want to understand. I don't understand.
Sorry?
Patients having intermediate reflux as a cause for pelvic
Actually, the most important thing if the patient has real May-Turner syndrome, because the definition of May-Turner syndrome, which patient should be treated, is just a big question mark. If you think that the patient has a real May-Turner syndrome, first you should treat the compression, not the iliac vein insufficiency. Yes. I always combine it with foam sclerotherapy. And first, I'm using the foam and then coiling upside. Yes. Yeah. No, I don't do in my practice at the same time. Because Actually, I'm let's say a bit conservative guy. Let's say I'm not trying to just making over treatment. I do it step by step and just give one therapy and follow the patients. And according to their symptom relief or still some persistence in their symptoms, I try to move on according to that. I don't do all the things at the same time. Yeah. Yeah. In Turkey, we only have polydoconol. Yes. I use 3%. Yes. Actually, it is not more than 10 milliliters, I think, because yes, I am measuring it with contrast. So I am giving my foam according to the contrast distribution. So I make such a balance. Especially for the pelvic patients, I don't use compression. No, yeah, I think it can be used, but in my practice, I don't use. Yes. Yeah, yeah, you know that it is very difficult to assess those patients, but I just look for the symptoms of the patients. But many of them, especially after 3 or menstrual cycle, mainly they are, let's say, relieving their symptoms. So the results are good. Yes. Actually, for the compression syndromes, it's a very, let's say, difficult point to discuss, especially when you think also after left renal veins compression, the nutcracker syndrome. Especially at this spine position, when you look, then many of those renal veins are compressed by the SMA. But we are doing now a dynamic duplex scanning for those, and I'm making the patient's upright position and checking it if there is a fixed compression or not. And many of them is releasing when you put the patients up. So, especially for deciding any compression syndrome, dynamic testing should be done. Many of our techniques are dependent on the spine position, and they are exaggerating the situation. And if you put the patient's upright position, look at again, many of the compression is disappearing. And I think for those patients with compression syndrome, we should train ourselves to make such type of dynamic testing. And when you think it, because especially for the nutcracker position, there are a lot of some other, let's say, vein taking the blood away from the renals. So you should be sure that not only the diameter of the vein, but you should also look for the reflux. But if you are sure there is a compression syndrome and it's fixed, you should treat them first and then just follow the patients, because according to one of my studies that I'm planning to publish it soon, the ovaric veins is the first collateral which is developing quickly after any central vein problem. So after some period when you treat them, they are downsizing again. So it's an important issue, just not to do everything at one time and step by step and follow the patients.
Okay. Thank you for the invitation. And I will present the treatment of pelvic, ovarian, and vulval vein with foam sclerotherapy in name of Dr. Tessari, that is not here. This is the disclosure of Dr. Tessari. And we know that 45% of patients that come to our office, they have not, with varicose vein, they have not great saphenous vein reflux. They have no saphenofemoral junction reflux in 45%. They have reflux only in collateral vein, in tributaries vein, and with the femoral vein that is well functioning, it is competent, and ostial vein is competent. They only the reflux in the pre-ostial vein valve. So this is the anatomy of pelvic veins, very complicated, and you see the normal anatomic findings. The both ovarian veins goes from ovarian to vena cava. Quite often there is a reflux in the left ovarian vein, and during pregnancy there is a strong relation between pregnancy and pelvic reflux. During pregnancy, the blood goes from left to right and return to vena cava with the right ovarian vein. When the uterus grow up, then there is an interruption of this flux with intra and extra uterine veins, and so there is a high pressure on the district of pelvic veins, and they goes down in the limbs. So external vein appear normally in right limb. I said that there is a strong relation between pregnancy and pelvic reflux. In a woman with no pregnancy, only 2% have a pelvic reflux. With one pregnancy, 15%, and 3 pregnancies, 65%, 4 pregnancies or more, 85%. So this is a clinical classification of the reflux. There is only a pelvic varicocele or pelvic varicose veins that are pelvic congestion syndrome or pelvic shunts. And this is an anatomical classification from Claude Franceschi that where this blood comes into the inferior limbs, comes from point E, inguinal or groin, in round ligament veins. And you can see here, it rains just from inguinal ligaments and come from left ovarian veins down to the vein of the ligament and into the groin and anterior part of the limb. The solution is sclerotherapy or surgery. As you can see here is the 4 cc of Sotre-de-Colle 3% or surgery with ligature of this reflex. We can have also suprapubic origin like a palma, natural palma, that is in this part of the abdomen, as you can observe here. This is just for sclerotherapy, a strong sclerotherapy with 3% of foam in many sessions. The other one is an obturatorian vein origin that comes always from left ovarian vein and arrive in the interior part of the posterior part of the thigh. Also here, sclerotherapy is a good method to cure it. Ischiatic vein or inferior gluteal vein is the posterior part of the thigh and joined sometimes with the external marginal vein. Clitoridal vein, as you can see, is just on the big lip of the vagina, and the sclerotherapy is very effective. But the most important is the P-point.
Dear doctor, your time is up.
Sorry?
The one is already in one way can summarize.
The time is not enough. Okay. So I'll let you see directly a short video for perineal vein in 2 or 3 cases, and in that position with the echo color Doppler we prepare foam with gas, 30% of oxygen and 70% of CO2. Then we check the vein, finger with the probe. We look at the vein is just inject.
Dear doctor, your time is up.
Needle. The time is over, so I thank you very much.